things that we, oh, let me click that. So
I got it. Yeah.
Okay, thank you. So first thing, let's play a little game of myth versus fact. MRA, or risk-adjusted payments, we always abbreviate them to MRA, exists to properly fund an entity for the additional cost of treating certain conditions. So it's not a real poll. You're not going to vote. Just think about your answer and see if we match. So do you think that MRA really exists to properly fund a group, a health plan for the additional cost of treating certain conditions? I will tell you that that's what we always thought starting way back in 2003, 2004, but it's not entirely the reason. So that's really more myth than fact. The whole idea is really to identify those conditions or categories of conditions that predict healthcare costs. Why? Because the federal government that runs the Medicare program looked at people like me, baby boomers, and my cohorts who are turning 65 at an unprecedented rate, and they needed a way to understand what those people coming into the Medicare program were going to cost them over the years. And so they identified conditions that affect a large number of people and also have very specific diagnosis codes. And with that, they were able to put together this payment paradigm. And I'm assuming that everybody knows what it is. I find it interesting that the CMS goal has always been to normalize the payments that Medicare Advantage plans receive for their enrollees, that they should be the same as what it would cost for a Medicare Advantage enrollee to receive care in the fee-for-service program. That always blows my mind when I read that, because if you've been around healthcare, you know that there are different incentives, and just the basis of payment for a Medicare provider seeing a Medicare beneficiary is completely different than the risk world of Medicare Advantage. But that's what it's all about. And so because they're comparing apples to oranges, they're wondering or analyzing, why is it that we see all of these health conditions coming across for Medicare Advantage enrollees, but we don't see that in the broader population of Medicare beneficiaries? Well, it could have something to do with the way providers are paid, but we'll move on to that. So the MRA changes that are coming down the pike starting next year is what I'm going to cover now. And I dragged out this slide from 2014, the first big changes that I remember them making to the MRA program in the CMS HCC model. And I remember thinking, oh, the world is over. Nothing stays the same. Oh my gosh, the world is coming to an end, because they had made considerable changes. And here we are doing it again. But if you've been around for a while, I'll remind you that back in 2014, CKDs 1, 2, and 3 left the model. The neuropathies left, old MI gone, decubitus ulcers gone, pressure ulcers stage 1 and 2 gone. So this is another very big change. And the good part was that in 2014, they put a lot of conditions into the model, like the pulmonary fibroses, the thrombocytopenias, things like that, that at least balanced it out. So there are considerable changes, and those changes have to do with the what, right? So the number of codes that are going to map to HCCs obviously are decreasing. And I'm assuming that some of you have heard this already from your plans, and they've been talking about this with you for a while. But we're losing about 2,000 codes, and it's not that they're changing the codes and repackaging them. They're gone from the model. Why? Well, I found the little phrase in the CMS announcement, because of discretionary coding variations. Remember that, because we're going to talk about that again. So because of that, they deemed these conditions that they're dropping to be less reliable predictors of future medical costs. Why? Because they looked at patients who had these conditions and said, wait a minute, they've had all these things for a while, and we don't see the associated increase in expenses that we would expect to see over the years. Another thing that they did with the model is remapping conditions from one HCC to another, or splitting some HCCs entirely. And version 28, which is what the 2024 model is called, will include more categories. So that could be a little bit deceiving because you think, oh, wow, well, this is actually good. More is good. More is not good. And I'm going to talk about that in a few. The version 28 phase-in is going to happen in stages, thank goodness, right? So beginning in January, the model that makes up the payment this year, which is version 24, is going to represent 2/3 of the payment that providers and plans get for their patients under this payment paradigm, which means that 1/3 is going to be based on the newer model. So today, you're getting paid on certain conditions, but starting in January, for that first period of January of 2024, your payments are going to drop by 1/3. In 2025, it'll flip, and 2/3 of the payments that providers and plans receive will be based on the new model, meaning that that model that doesn't contain a lot of things that we've been used to seeing, and only 1/3 will be based on the old model. And then by 2026, 100% of the payment will be based on the new model. So you're probably like holding your breath and thinking, all right, what's changing? They added a few things to the model. I don't know to what to expect that they're going to be very earth-shattering, but benign carcinoid tumors, I've not seen very many. Retinal vein occlusions, okay. I mean, they happen from time to time. Severe asthma is one to have a look at. Bile duct obstructions and malignant ascites. Now, I've never really paid attention to asthma because it was never risk adjusted. And, fortunately, I don't have it. So it's not something that was on my radar. But there are actual criteria, which we'll, blog about in the coming weeks. But there are criteria for how you classify asthma as severe, because history has proven that all of a sudden, everybody who's had mild asthma, all of a sudden starts to develop severe asthma within the first few months of 2024. So we'll go over that and we'll blog about that. Feel free to check our website. Some other changes that they made, or additions of codes, really have to do with patients that are not in the normal adult internal medicine family practice. So a lot of newborn conditions, things affecting babies, birth injuries, congenital diagnoses. So they're not conditions that we're going to expect to see as plentifully as we see the ones that are leaving the model. And so with that, what's also changing, you might ask? Well, vascular conditions are going bye-bye. That means that atherosclerosis of anything, of the aorta, the renal artery, the iliac artery, gone. And if you've been doing this work for a while, or you're a provider, we see those with a lot of regularity. Aneurysms will also not be under the model because they're not deemed to be predictive enough if they haven't ruptured. Remember what we said, discretionary coding variations? Well, peripheral vascular disease is also exiting the model. And, I'll tell you a story. The clinical criteria are very important, and we're going to really talk about that a good bit over the next half hour, because in code selection, you've got to make sure that you're picking the correct code and that it's based on clinically reliable information. And we've seen a rash of providers diagnosing patients with PVD because they have carotid stenosis. If you're a coder and you put on your coding hat, you know that coding is specific. And so when there is evidence of a condition like carotid stenosis, there are codes for that. And those are the codes that have to be reported. You can't say, well, it is, but I consider it a peripheral artery, and so I'm going to call it PVD, which just happens to pay, as opposed to carotid stenosis, which doesn't pay. So those are things that I believe fall under the whole discretionary coding variation that may have had a hand in prompting some of these changes. Other arterial issues that we find with a lot of frequency: tortuous arteries, ectatic arteries, those are no longer going to be in the model. On the endocrine side, Diabetes, which since the beginning of the MRA model, had payment differentials for patients who had no complications or who had other types of complications. Eventually, they streamlined and made it diabetes with no complications, with acute, and with chronic, and they lumped everything in to those three categories. Well, now there's one diabetes factor. There's one payment for diabetes, whether it's complicated or not. We also know, if you've been doing this type of work, that many of these diabetic complications used to or still may have their own payment component. So there's a payment for the diabetes having been complicated by a complication, sorry to be redundant, but then neuropathy had a payment or retinopathy had a payment. Well, those were removed from the model a while ago. Now, the most common ones that are left that generate an additional payment are the proliferative diabetic retinopathy and CKD stages 3 and above. So those are the only ones. Consider then that there won't be, or there shouldn't be, any incentive to see patients with 5 different complications because there's really no payment associated. And it doesn't seem to have an impact in the patient's medical expenses over a long period of time. In addition, glandular conditions, so all of those that were added in 2014, the adrenal and pituitary and parathyroid issues, those are going bye-bye. Malnutrition, that one was a little bit surprising. And again, going back to that phrase, discretionary coding variations, there are guidelines for how you assess and diagnose malnutrition and cachexia. But we've done a lot of chart reviews where people base it only on BMI, and the patient has a low BMI. And by virtue of that, the practice is reporting malnutrition codes. Well, that's not correct. There are people who are thin. I am not one of them. I don't even know what that looks like. But I do know that there are people that when you review their charts, you can see over years, their weight really hasn't fluctuated and their labs are all good. And everything else shows them to be healthy and not malnourished. So consider the basis for why they're removing these things from the model. What else is changing? Well, on the cardiac side, all the anginas are going away. I mean, that one alone, all of these like generate a moment of silence that I feel like we have to have. So the only anginas that are going to be left are the unstable, and those are things that you're not going to see with regularity in an outpatient practice. The heart failures, interestingly, are being split into acute and chronic HCCs. So remember when I said, oh, remapping things is not necessarily a good idea or good news. Well, I believe that you're going to see in the coming years that there will be a hierarchy or a payment differential between the acute and the chronic heart failures. So the acutes will obviously pay more and the chronics won't. So there's a reason why they're mapping them to different categories. On the hematological side, all of those penias that came into effect in 2014, the purpuras that we do see with some frequency, thalassemias, immunodeficiencies, coagulation defects, those are all being removed. I feel like I need to send you guys like something to jazz you up because this is a little bit depressing, but it's not. Stay tuned because there are things that we can do. So what more can possibly change, you might be asking? All right, neurologically, the degenerative diseases like cerebral atrophy, which is something that we find a good bit in charts, bye-bye. The rest of the polyneuropathies that they didn't wipe out several years ago are gone. On the renal side, acute renal failure, the hyperparathyroidism we talked about, dialysis and toe amputations. And then for the love of God, what else? What else? Rheumatology. Sjögren's, inflammatory spondylopathies. I will tell you that our experience has shown, I've seen some interesting things. I've seen patients who have, dry eyes diagnosed with Sjögren's with, beautiful rheumatoid panels, no abnormalities, nothing like that, but either they have a dry mouth or dry eyes, and that's not enough. Spinal enthesiopathy and sacroiliitis, here too. We see patients with back pain. One day they have back pain, the next day. So again, I don't know if these are the discretionary coding variations that CMS is basing its changes on, but it could be. And it also is going to set something up that we'll talk about in a couple of slides, because if your charts are full of these types of conditions, we need to talk. On the psychiatric side, bipolar disorder, major depressive disorder, single episode, and recurrent in remission are out of the model. And so are MDD, single episode, and recurrent mild. So that is an interesting one, because we've done a lot of charts and actually reviewed, back in ICD-9, patients who had, the general garden variety depression code, and they were bumped up to major depressive disorder without meeting the guidelines. And so that's all been dragged through people's charts. And that could be why that, once they're stable and they're considered to be in remission, that CMS doesn't necessarily want to continue paying for those. Toxic effect of tobacco, cigarettes, intentional self-harm is a code that we see every so often, that providers use when a patient, let's say, develops emphysema or COPD and was or is a smoker. And I guess the providers think that these patients are intentionally trying to hurt their health. So if you're wondering what is the financial impact of all of these, because you're recognizing that a lot of these conditions are things that your patients have, or that you find on chart reviews, or you see reported with a great deal of frequency, I can't tell you because we are not financial people. But I am confident that you have heard from your health plans and your plan representatives, and they've already told you about these changes and given you a sense of what the financial impact could be to your practice. I will tell you, I've heard numbers like $45 PMPM reduction in funding, which is pretty considerable. Anecdotally, when we learned of the changes, we started looking and analyzing the charts that we were reviewing. And when we looked at the conditions that are coming out of the model, we saw that they were probably about 50% of the conditions, 50 to 55% of the conditions that the patients had across the board. So, for a long time, we kind of considered them a little bit of low-hanging fruit, if you will. Like, I remember a provider, when we explained to him that atherosclerosis of the aorta was a risk-adjusted code, he was like, "That's crazy. That's like getting paid for having gray hair. They all have it." I said, "That's right. They do. It's in the model. Code it and assess it and do a good job with it." So what are we going to do? I'm going to tell you in a quick second. Do you feel like you need a breather? You need to like a little woosah? I will tell you that my drug of choice, chocolate, always, because I prefer to chew my calories, frankly. But that aside, what do we do? Because this is a very big change. And so I will tell you what we have told all of our clients and what we strongly recommend. The path forward is really two paths. There are two parallel paths to follow going forward. And there is light at the end of the tunnel, and it's not a train. So think of them, and I am not a football connoisseur, but think of them in terms of offensive and defensive approaches, right? So the first one being the offensive approach, maximize. So one of the things that we advise all of our clients to do is you need to get busy and make sure that everything that your patients have, you are reporting, you can support it, they're coded correctly, and they're being submitted, and that your documentation is robust. I know you have a process for bringing in your members, making sure that they come in a certain number of times per year, and you'll continue to do that and use telehealth, audio, video as much as possible between now and the end of the year, because this year it's still 100% payment for these conditions. So if somebody's been dogging you and they're not coming in, you know, telehealth, send somebody to their home, I don't know, but try to get a visit with that member so that you can make sure to report the conditions that the patient legitimately has. On the defensive side, I would say scour your charts. Oh, the defensive approach is protect. So we're maximizing and we're protecting. And you're probably thinking she has lost what was left of her mind. Oh my gosh, she's giving us the same instructions or the same approach for both. I'm not. What I'm trying to say is these are two halves of the same coin. On the one hand, we've got to maximize, but I'm going to spend time on the protect part because it's sometimes neglected in most medical practices until someone from the outside, a CMS audit, a health plan audit, something triggers it, and then we're panicking, right? So CMS has a look back period that's about 6 years now. They lowered it. Medicare Advantage has a longer look back period. So I'm going to tell you that things that you reported maybe, 10 years ago are being audited at this point. And I'm going to go into that in a little bit more detail. So that's why I'm saying, on the one hand, yes, identify as much as you can, go back through your charts and make sure that you have uncovered everything that that patient has. But on the other hand, make sure that you've observed clinical and coding criteria, you've coded them correctly, and you have got good support for those conditions so that you don't have to look over your shoulder and expect that somebody's going to knock on the door in 5 or 6 or 8 or 10 years and ask for some money back. And it's happening because the current environment features the OIG very, very prominently. And the buzzword and the idea behind it all is compliance. So I'll just give you a couple, and every few months there's another plan. So even though these 4 names are up here, there have been others, but it's all variations on the same theme. Cigna, for example, was cited for improper diagnostic codes for things that members did not have. So they submitted improper codes for things the patients didn't have. They weren't even in the medical record and not based on clinically reliable information. They incentivized doctors to find conditions to raise risk scores. That's a big no-no. Anthem knowingly submitted inaccurate codes, that's what the OIG said, and ignored its duty to delete inaccurate diagnoses. Humana reported unsupported and unassessed MRA conditions, and Kaiser pressured providers to create invalid addenda, often months or over a year later. I know I read that and it just blows my mind, to add conditions that the patients didn't have or were not considered or addressed during the encounter. This is big. And so it's important to consider what it is that you have in your charts to support the conditions that you are sending in. We know that there are coding issues, there are coding mistakes, they happen. Sometimes things are keyed incorrectly and they get logged in, and pulling reports from your practice management or your EMR system is important so that you can spot check or create a process where you can spot check to make sure that there really is support for these conditions. At the bottom of the slide where it says addenda are good. I mean, there is a proper way to use an addendum, and this is the time of year to do it because we're at the end of the year. So when a provider begins to address something with the patient during the visit, but then needs a little bit more information. Let's say I'm going to order a test and but I think you might have a clot in your leg. Let's order this test and we'll see. The test comes back the next day and the test is positive. Well, at that point, the provider can go back and make an addendum to the visit note and add that medical condition, that diagnosis code, and then explain this is an addendum to yesterday's visit. Sally Smith's venous ultrasound came back and showed blah, blah, blah. Add the condition, make sure it gets billed. And that would be a correct way of making an addendum. Why would you want to do that? Because you want to make sure that that code gets transmitted and triggers the payment that it should trigger, because now you have a test result that supports it. So you started the conversation with the patient during the visit, and you needed one more thing in order to close that loop, if you will. That's very different than, oh my gosh, I forgot she had A, B, and C. Let me go ahead and add them to the visit and process that encounter. That's what they're talking about Kaiser having done, that they just added things that either people didn't have or that they weren't addressed during the encounter. So think about between now and the end of the year, if there are labs that you're ordering, maybe you need another lab to verify that a patient has hyperparathyroidism or something like that. Have your provider talk about it during the visit. You know, last time it was high, but we need a second lab. We're going to run that lab, and then I'll give you a call or have you come back or whatever it is. But usually give them a call, at least so that you can make the addendum. So that's, I know I'm kind of talking in circles, but that's the important part. And then when you do your own reviews, if you see inaccurate codes that were reported, you have a duty to delete them. And every plan has a process for how you submit codes that were erroneous so that they can be removed from the patient's medical profile. I would say don't drag your feet on that, because right now you have 100% of the funding. You don't want to have codes removed in 3 or 4 years when you don't have the benefit of the additional funding. So just something to file away. Some things that the OIG is looking at, they're looking at CVAs, they're looking at cancers, they're looking at MDDs and dependencies. So all of those drug dependencies, I will bet you money, money. Anybody can take me up on this offer. I will bet you money that your drug dependencies are not all valid and your MDDs are not all valid. Send me an email if you want to take me up on this deal. No, truly, there are criteria, and I know I'm making light of it, but I'm really not. I'm trying to keep you awake, but also I'm trying to help you understand that this is the time to streamline and fix anything that you find in your charts. Why? Because that's the protect part. Providers have done a really good job over the years with the maximize. I've seen some creativity out there. But now we need to also protect the money that you're getting paid and that you've gotten paid, so that you don't end up paying it back. Which means that the burden of proof pretty much falls on the PCP. Accurate coding, because everything risk adjusted is coding specific, which means that laterality is important. Specificity is important. So if you report a code that says unspecified leg, but the test result specifies the leg, that code that you reported is not the correct code, and that can be removed, and with it the dollars. So pay attention to the coding, adhering to clinical and coding criteria, making sure that the information that is supporting the conditions that are in your patient's charts and that you are reporting have a basis, and that there's a little bit of story that bolsters the reporting of that code. We suggest that evidence should always be documented on the progress note. Make a reference to a specialty consult, to a test result, to an item in a hospitalization, but there should always be evidence on the note that points to where the proof of that condition can be found. I told you my PVD carotid stenosis story. COPD from a chest x-ray happens a lot, used to happen a lot. So, and that's not the correct evidence for COPD. It's a pulmonary function test. So those are the types of things that you want to be on the lookout for. I would say, you know, I always say not all evidence is evidence. And I'll tell you not so funny story. So that's why I'm saying, look at the evidence that you have supporting the conditions that you've reported. Perfect example. we were working with a client, and a cardiology group was reporting that the patients had angina, a lot of them. And the patients never complained of it. The PCPs were even saying, wait, what? But the coders in the practice were just dragging it in because, hey, the cardiologist said this patient has angina. So I met with the medical director, and I said, I'm a little bit lost because we're looking at the tests that these patients have done. They're all negative. There's no evidence that the patient has angina, yet you're coding it. And he says, oh, I kid you not. Don't look at my first note, because I have to put down that code so that I can have my tests approved by the plan, because I need to do an echo and a stress test. And if I don't put that code, they're not going to approve it. So you need to look at my second note. And I said, oh, wow. All right, that's interesting. So that's why I say, look at the evidence that you're using and make sure that it really is legit. And then document a proper assessment. And I'll tell you what that's going to look like in a second. Since 2015, I will tell you that about 30% of the work that we do has been validation audits. So the plans have a requirement to validate the codes. When they find abnormalities or they find codes that are not supported, they can commission a larger audit. And that's where, we've had to do quite a few of these. So that's why I say protect, 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 maximize, but also protect. So myth or fact, last one of these, MRA results in payment for entities because the patient has a specific medical condition. No, the payment is because the providers are managing the medical conditions. And how do they do that? You prove that by what's documented in your note. Same way that attorneys say that when they're writing an email or a correspondence, they're really writing for the judge who's going to review that specific piece of information in the future, if a lawsuit should happen. We're documenting for the auditor who's going to review a chart or question a diagnosis. And so we kind of have to keep that person in mind and package these notes with as much of a bow as we can muster. So the requirements of an assessment are usually MEAT, right? You've probably seen this before. Your assessment should show how the condition is being monitored. So the signs, symptoms, disease progression. E for evaluation. So the provider's evaluation of the condition should be very evident on the note. Test results, medication effectiveness, comments like this. A for assessing and addressing. So the discussion of how is the condition doing. And then finally, T for treating. So any medications or therapies that are being used to treat the condition. One thing that we see sometimes that providers have a tendency to report all of the conditions that a patient has at every single visit. And I would say that's a little bit overkill. I would rather that you report and document a really solid note a few times a year and have a good assessment that's going to safeguard your payment, as opposed to putting a laundry list of 15 things on every note and a substandard assessment. Because when I review charts, we all do, we look at that. And if the assessment really is lacking, it could be that your codes may be reversed. We created this SAT for medical documentation for a client, and I thought I would throw it out there. This is like the basics of acceptable documentation, like the bottom rung of the ladder. But think in terms of mentioning a symptom with an adjective and then treatment. So something about like their shortness of breath is improving. She's improving. She's going to continue on whatever. Her the pain in her whatever is lessening, or it's better, or it's resolving, and she's going to continue taking this. So if you want, we have a laminated card with, it's double-sided and has a list of the adjectives on the back. So if you'd like one, feel free to send us an email to info@askccg.com, and we'll be glad to send you one. Again, this is truly the very basic of documentation. Sentences are always, always better. A couple of other reminders: watch for cloned notes. CMS defines this as, copying and pasting information from one note to another, substantially similar notes. And we've seen it where we've reviewed charts, and with the exception of like vital signs and a couple of things here or there, wow, you could put two notes together and you can't tell, are these the same visit? And they're not, because the vitals are different. So just be careful of that. Vary your wording, even if, a lot of times your patients are stable, continue to monitor. That's really the basic assessment. Try to jazz it up a little bit. Ask us for one of those SAT cards and we'll be glad to send it. And new patients. Now, I know this will be controversial, but a lot of times when you see a brand new patient and you don't have any records, we always advise our clients, be careful when you're documenting these conditions, because you need the evidence. The burden of proof falls on the PCP. CMS says you cannot diagnose a patient from the medications that they're taking. Makes sense. Medications are often used for more than one condition. In addition, the patient said is not evidence. It can get you started, but it's really not evidence of a condition. The patient says she has heart failure. Okay, great. So that's where a detailed history is helpful. So tell me, when did you develop heart failure? What were some of the symptoms that who were you seeing? What medications have you been on? Those types of things. And try to document a little bit of a story that helps support the condition while you're waiting for records. Our suggestion would always be, if you don't have solid evidence, don't code those conditions. Mention them in the HPI and say the patient reports that she's got A, B, C, and D, and we're requesting those records. So that way, you're watching out for them. But once you put them into the assessment and you report them, and then the evidence doesn't come, or it's not what the patient said it was, then at that point, you're stuck because you've already sent it through, and you have a responsibility at that point to submit a removal to remove that code from the patient's medical profile. Now, I know this last comment is a little tough. Prior PCP notes are evidentiary trash. I say that with love, only from the standpoint that, again, a new PCP who gets PCP notes from somebody else, where's your basis for a condition? It's got to be more than the prior PCP said, because maybe the prior PCP was one of those that said, oh, you have hyperglycemia, you have a disorder of carbohydrate metabolism, or one of those. So we need to be careful. Old PCP records are wonderful. You want to look at labs, you want to look at consults, radiology, hospital, all those wonderful things. PCP notes that have PHQ-9s, those are great. Or who may document the criteria for a dependence on a medication. So those are wonderful, but for run-of-the-mill conditions, you want the evidence that is the objective evidence, either an exam, things like that. So with that, I will take a breath and see if I'm going to unhide myself. Here I am. And see if you have any questions.
If you do have any questions, feel free to unmute yourselves and go ahead and ask the questions at this time.
No questions.
Yeah. Let me ask you a question, Alex. Since I am a novice and really didn't understand much of what was going on in your presentation, but that's okay. If they're taking away a code, but you still have the condition, how do you handle that?
Well, it just doesn't trigger a payment. There are a lot of conditions. I mean, really, probably about 20% of all the diagnosis codes, and that may be a little bit of an older number, had additional payments attached to them. So gotcha. Patients still have vertigo, they still have, ear infections, they have a lot of things that don't trigger additional payment. There's a standard base payment in the Medicare Advantage world for a member. And there are, it's affected by age, sex, location, things like that. The additional payment, but it's kind of like the first rung of the ladder. The additional payments come for all these chronic conditions. And once they're not in the model, you're still treating them, but they're included in the payment that they're receiving.
So you're getting one payment where before you might have gotten 2 or 3 for a similar condition then.
Right. Because all those other conditions add dollars. See, I have to talk with my hands. That's what I've been doing while I've been muted. All those additional conditions then bump up the payment.
Now, is this just for Medicare Advantage plans or straight Medicare also?
No, Medicare Advantage plans. And then if for straight Medicare, like patients who are in an ACO, they're tracking this type of payment because they're also providing bonuses and other things like that based on the dollars that come in and utilization. So it'll affect providers for patients that when they're in an ACO.
But if you're just a straight Medicare patient, that doesn't affect it.
No, because straight Medicare patients, providers are paid based on what they do, not based on how sick the patient is. So they're paid based on the type of visit and the intensity and the complexity of the decision making of the visit. Those codes are not affected by diagnoses. Diagnoses just justify the medical necessity of the visit.
Gotcha.
So that's why it's apples and oranges.
Right. Okay. Okay. Good. So does anybody there have a practice that this would definitely have some bearing on or work for a practice?
Maybe I bored them to death.
No, I think sometimes, wait a minute, we have somebody unmute themselves.
No, honestly, I think you did such a fantastic job of covering everything.
You.
So I think it's just that on my end, that's gonna have a big impact on the practice because we are 95% HMO risk practice. So definitely I took to heart everything you said. So now I understand as far as the offense and defense. From my understanding, there are new codes that's being added as well.
There are new codes. The unfortunate thing is that the new codes that are being added, at least for next year, are things that they don't balance out because, for example, and I mentioned a lot of newborn types of conditions and birth injuries, congenital defects, things like that you don't see with the same regularity in an adult. Well, you don't see it in an adult primary care practice. So the balance is not there. What they're adding is either acute things or congenital conditions that will not balance out what they're removing. I don't know what the plans have said to you, if they've given you a sense of financially what type of impact this is going to have on your practice, but it's not going to balance out.
Yes, I kind of figured, but from my understanding, although they are removing 33%, I think, every year, but from my understanding, it's 33% of the premium for those codes, correct?
33% of the fund, well, 33% of the, well, wait, let me back up.
Okay.
The funding that's calculated for a patient, you've got the base payment, right? That has to do with age and sex and if they're institutionalized or not. And then on top of that, you have all of the different risk-adjusted conditions that bump up that payment. Well, they're not going to be there. They're going to pay you 1/3 of the payment next year for those conditions. Now, if the patient has cancer, the payment's unaffected. If the patient has COPD or emphysema, the payment's not affected. It's only for those conditions that they're removing from the model. So all the vascular, the DM differential, those types of things.
Okay.
Okay.
No.
Remember, defense, offense, you can do it.
Great. Any other comments or questions?
Yes, thank you for the time and for giving this great explanation. Unfortunately I got here a little bit late, half an hour late, and I didn't hear most of the
Oh.
important part of the conference. But and so there all these atherosclerosis of the aorta, depression, dependence. These are all the codes that are being removed for next year.
No, not all the codes. And as a matter of fact, Charles is going to post the video, so you'll be able to, you'll be able to watch it again, especially if you can't sleep at night. I would recommend it. But and you can always give me a call, and I'll be glad to, explain anything. But the atherosclerosis of the aorta, the the other anginas, all of the DMs are going to be paying the same. Now I can't think, but yeah, they are removing a lot of those more common, the PVD out, the thrombocytopenias, all of the adrenal, those types of glandular issues that,
Okay.
yeah, gone.
Yeah, but
Alright.
the video will be posted by, let's see, today is Tuesday, by Thursday on my website, and you'll be able to see in video presentations, and you can catch it on the website. And we'll have it. We started a couple of minutes late, so a couple of introductions. First two slides, it's my fault. I was asleep at the switch for a second. So, but you'll get most of it. It was only for maybe 2 minutes or so, but you get most of it. So, Vicky, you got a question?
Yes, I was wondering, is this the only presentation you're doing where you go through it versus us looking at the video?
The answer is probably yes. What are you trying to get at, Vicky? And maybe we can help you.
Like if you wanted to hear it again, or is there another meeting besides this one?
Oh, he's posting the video so you can listen to it again from
Okay, so
start to finish.
Right.
All right.
So you can listen to it again, make notes. This is what I would do. Listen to it again. I'm sure everyone made some notes. Make some notes again. And then I will also, you take a look and you'll get the information for Alex for Coleman Consulting, and give Alex a call if you have any questions relating to those that you comment afterwards after you rewatch the video. Because once we go through it once, but you can stop it and start it and re-listen to it, and something there that, that all of a sudden, well, I really wanted that. I'll get it. Angela, the website is going to be, it's going to be on South Florida Hospital News. I know you get my newsletter, so I'm sure you can get to my website. And at the bottom of the website, there is some what do you call it? Buttons that you can find for video webinars, and it'll be under that one. It's also going to be posted if you search it through YouTube, because I use a YouTube channel for South Florida Hospital News.
We have lots of blogs on our website, so you'll see that on the web address on the front slide that we discuss all these changes. So
Okay, thanks.
sure, thanks for the question.
So this is South Florida Hospital News, right?
Yeah, South Florida Hospital News. You can check my website out. Yeah, we have a lot of information, a lot of robust information about it. And also, I will send Alex for Coleman Consulting the link to where the video is. So even if you go to her site by the beginning of next week, you'll be able to see it on her site too.
Fantastic. Thank you so much.
You're welcome. Thank you for attending.
All right. Okay.
Well, I appreciate it. Now, just remember, next week we do have another video. The other webinar is a legal webinar, and the topic escapes me for right now, but tune in next. You'll see it in my newsletter on this coming Thursday, which I'm sure you get because you get every newsletter. If you turned on to here, you got the newsletter. And we will, it's a very good seminar about the legal relationship between doctors, hospitals, and physician offices and practices. So,
okay, very good. Well, this is all very helpful. I'm just gonna start my first at-risk contract with for Medicare Advantage. So this comes in very handy.
Okay,
this,
good.
this webinars, and hopefully it'll be a good year next year. I don't know.
It will, it will.
But you know, doctors, they don't train us for business, the business side of it, but I guess we have to learn the hard way.
Well, the
So
other thing is it's all coding based, and coding has rules that they don't go through that with you. So, you know,
right,
it's hard.
it's hard, but you know, it's just very time consuming, but it's doable. So thank you very much.
You're
And
welcome.
I guess I'll be joining you next week.
Okay.
Yeah, okay, great. And like I said, any questions you have or you need some help relating to your businesses or anything else, Alex and Wilma are there.
Oh, feel free to call. Yep.
Feel free to give them a call, and they can help you out. So that's what they do at a lot of physician offices. So with
Okay.
that, we're at about 7:30, 7:28. Again, I want to thank everybody for joining us, and again, presented by South Florida Hospital News, and also Coleman Consulting, and Alex Johnson and Wilma Torres. Thank you very much.
Thank you, Charles.
Okay, thank you, everybody.
Bye-bye.
Bye.
Thank you. Good night.
Happy Thanksgiving.
Bye.
Same to you.
Bye.